Thank you, Dr. Talavera, for the lovely introduction. I really appreciate it. And I'm really excited to be here tonight to talk about a topic that's really meaningful to me, and that's the biopsychosocial approach to pain management. And some of my goals with this is that, this lecture is actually open to the entire community, the entire nation. So it may be that some of you are already connected with Stanford providers, and maybe you've heard that term before because that's an approach that we like to take with pain. Perhaps aren't connected to our community, and maybe it's a new term. Regardless, this lecture tonight is for any of you who might have a base knowledge of what that means, or if that's actually new terminology for you. And my goal is really that this term gets used often, the biopsychosocial approach, and I really just want to break that down and demystify it and really kind of teach everyone here, what is that and how do we use that in our pain management strategies? So of course, that conversation can't happen without talking about pain. So I'll spend some time dedicated to the evolution of the definition of pain as it's published. And then I'll also be talking about the differences between acute and chronic pain. And then lastly, my hope is to leave you with some pain self-management strategies. So I'll teach you these things and then hopefully give you some skills and resources that you can take with you. And I will likely be ending about 10 minutes to the hour. So hopefully we'll have about 10 minutes for conversation. So the first important piece to this is really talking about what is the definition of pain. So you'll see here on my slide that I have two definitions. One is from 1979 and the other is from 2020. And this definition is published by the International Association for the Study of Pain. So this organization actually publishes the definition that's most widely recognized by healthcare professionals such as psychologists, physicians, physical therapists, and it's also recognized by the World Health Organization. So when your providers are working with you, they're working with you from this knowledge base here, from this definition. And it's really actually quite significant that this organization decided to make a change to the definition of pain. And I want to talk about that history because I think if you are someone who is living with chronic pain, or if you're here on this lecture supporting someone who has chronic pain, you'll see that your lived experiences were taken into consideration. So a few things that I want to talk about when they created this definition or revised it, they really put a lot of thought into it. So this took place over a 2-year period from 2018 to 2020, and they actually had a 14-person task force. And in addition to that, they invited other professionals such as philosophers, linguistic experts, bioethicists, and even presented a potential definition to the community and requested feedback and took that feedback into consideration. So if you look at this old definition here, some of the critiques of this old definition were, if you see the word, let's see, where is it? Described. So described in such terms of such damage. So really the critique of the old definition was that it focused too much emphasis on verbalizing and expressing your pain. And so they wanted to make some changes. So you can see here with the new definition, there isn't a mention of described because they are recognizing that sometimes if someone is living with pain, maybe they don't express it, maybe they don't articulate it, maybe they don't verbalize it. And so they wanted it to truly be open to those who maybe choose not to express, or maybe those who don't have the ability to express it verbally, such as infants, non-human animals, as well as people with different types of cognitive ability. So really it was, like I said, moving the emphasis away from having to have people articulate it verbally. In addition to that, they wanted to really not tether the cause of pain to sort of a stimuli or stimulus. And so what I mean by that is that they were trying to move away from suggesting that pain has to be associated with some type of tissue damage. So you can see here now, I've bolded what was added. So pain is an unpleasant sensory and emotional experience that is associated with or resembling that associated with actual or potential tissue damage. And that is because even though oftentimes with pain, tissue damage can be an antecedent to feeling pain, it's not always the case. And we'll actually talk about a few case studies where there can be pain in the absence of tissue damage. In addition, if you think about neuropathic pain, sometimes a person can feel pain in an area where there isn't tissue damage. So it was really trying to be adjusting to the evolution of science and what we're learning about pain. In addition, I think that this is really important, and I care a lot about this as someone who works with people who are living with chronic pain. It wanted to take into consideration sort of that it's the person who's living with pain, their experience of it that matters. So they explicitly noted in some of their work, the notes from their work group, that it doesn't matter what a provider is observing. So me as a fellow, it doesn't matter what I see or how you're presenting. It doesn't matter what a physician sees. It doesn't matter what a pharmaceutical company sees. It's literally, what are you experiencing? And that's what matters. And that's how pain is defined. So I really just appreciated these changes because it certainly encapsulated the experience of someone who is living with chronic pain. Or actually, I take that back. This definition also was sort of adjusted because it wants to capture all types of pain, whether it's acute pain or chronic pain, regardless of any of the pathophysiology. So it's meant to be all inclusive. I typically work with chronic pain patients. So here's some additional information. So there's a really nice visual. I didn't have the rights to it to be able to put it in my presentation today. So I've literally taken verbatim quotes from the work group. And so basically everything here is important, but I've highlighted sort of the aspects that will be important to my lecture tonight. So the piece that I'm going to get out today is this first sentence here. So it's basically saying that pain is influenced by varying degrees by biological, psychological, and social factors. And still that might seem kind of like a loaded sentence. So we'll break that down and I'll do it in layers. But essentially we're saying that biological, psychological, and social factors can influence the pain trajectory, the pain onset, and pain can influence those domains as well. So if you're feeling pain, as an example, perhaps you feel a little more depressed, or maybe you're feeling anxious, or maybe you feel sad. And so we'll go through each of those. I think this one's important too. Throughout the life experience, individuals learn the concept of pain, because basically what that's saying is that your idea of pain can change throughout your lifetime. One of the probably most illustrative examples that I can provide is when I'm working with someone, they'll say, well, yeah, I maybe would have rated my pain as a 10 out of 10 today, but I gave birth to a child, or I've had kidney stones. And so now I've sort of shifted how I prefer to measure my pain. And if you're interested in like assessment of pain or measuring your pain, we're going to have a really great lecture either in October or November by Dr. Steinman, who's going to do a topic on measuring your pain. So one way to talk about this, I'm going to, please bear with me, I'm going to step outside of pain for maybe just about 5 minutes. And then I'll move all of these examples into pain. And the reason, so this is an article from 1977, and I think that this is so seminal. So this article really illustrated, like, what does it mean to incorporate the biopsychosocial model in treatment? So to give you a little background, and I am simplifying this just a bit for the sake of the lecture tonight, but Dr. Engel, the author of this article, he was a professor of psychiatry and medicine. And for those of you who aren't aware, psychiatry is a part of medicine, and they're dealing primarily with like behavior or psychiatric illness. So at the time of this article, he stated that psychiatry and medicine were experiencing a crisis. So psychiatry's crisis was, they weren't really sure, human distress. When you think about psychiatry, they felt it was treating human distress, and they wanted to know, is human distress, like, should that be classified as a disease? And are, medical doctors the right people to be treating that? On the other hand, medicine, the crisis that they were experiencing, they were looking at things in terms of like somatic parameters. And when I say that, I mean that basically it's like separating the mind from the body. So really wanted to treat primarily the body without giving acknowledgement to the psychosocial issues, which I'll explain what that is if you're not quite sure. So psychosocial issues are looking at relationships, looking at individual thoughts and behaviors, and looking at the interrelation between all of those things. So what he did is he said, really to show people how important the biopsychosocial model is. And like I said, every example I have here, I will have a very specific one about pain. He said, we have to look at two different types of diseases. One that's considered more somatic in nature, so that's represented with diabetes, and one that's considered more mental, like mental or psychiatric in nature, and that was schizophrenia. And so what he argued when he was saying everyone needs to embrace the biopsychosocial model was he said, okay, let's take a look at genetic and biological markers. So if you think about it, biomedical, that model means it's really like medicine is using a base of like molecular biology to kind of confirm whether or not disease is present or not there. So what he stated is that, okay, like even if someone has the biomarkers and it indicates that someone could have a disease, it doesn't actually indicate the actuality, but it indicates the potentiality. And we'll talk about that. I'm actually going to talk about a study where we look at scans of people who presumably would have lower back pain based on the abnormalities, but they don't. And so really it's kind of saying there can be something there, but it doesn't necessarily mean that the disease is present. In addition, he talked about expression. I think this was really, really key. So he said, okay, say we decided to do everything from a biomedical model. So say we decided to just look at things from biological abnormalities. Well, what good does it do to know what that lab documentation would be if you don't know how it's expressed behaviorally or even emotionally? Because if you look at ethnomedical perspectives, how disease was classified was generally how people presented with changes in behaviors or what people noticed. And in addition, when he made a comparison between diabetes and schizophrenia, he said that there's some overlap from some of the symptoms. So if there's a crisis with diabetes, that can look a lot like potentially like a psychiatric crisis. And similarly with like schizophrenia or even just stress in another type of domain, some of those symptoms could look like they are actually of diabetes. And so context is very important. So how people express illness, what context it occurs in, these are very important things that we have to know to be able to treat disease appropriately. He also noted that there are variables that impact onset and manifestation. So we're going to talk a little bit about trauma and how that connects to pain. We're going to talk about social determinants of health and how that impacts pain. So if you think about it with either of these illnesses or diseases here, when the onset of it, like what the trajectory, it could be completely different based on, well, who has access to medication or medical care or psychological care, who has access to green space or healthy food. That is going to change sort of the trajectory. So these psychosocial issues are actually really important. He also noted the importance of perceptions of illness. So it's kind of like looking at so even if there is sort of a biological abnormality, when does a person decide that they're ill? And so if you think about it, that could be impacted by, does someone have health insurance to be able to become a patient and get help? I hear often about sort of cultural values of, I'm not allowed to be ill or sick because my family needs me, or it's sort of a cultural tradition that I can't allow anyone to sort of see me be what would be perceived as weak. So there are many other factors, including cultural, that can impact when someone decides that they are a patient. And then also, I think a lot of people here could probably relate to this. Like, even if you treat that abnormality, that doesn't always equate to feeling better or being restored. And actually at Stanford, there's research to suggest that even if we do everything right and we help reduce pain, we actually have to target functioning separately, because it doesn't mean that your functioning improves or correlates with that. And then lastly, the relationship is so important. So actually, we have to look at these psychosocial relationships, in particular with your provider. So I can imagine if someone didn't feel comfortable with their provider, or didn't feel very trusting of what their provider was saying, or didn't agree with the treatment, that person is less likely to move forward with that. And so I think this article did a really beautiful job, and it's one that I use constantly in my work to really reflect on, why is it so important, yes, to include the biomedical aspects of treatment, but also to include psychological and social aspects. So now let's bring all of this into very explicit pain examples, which I think is what you're excited to hear about. So when I talked about, sometimes like the presence of an abnormality doesn't always mean that there could be pain in this case. So Jensen and researchers ended up, what they did is they took, approximately 100 people, it's actually 98 people, who weren't talking or discussing or any pain issues whatsoever. So they were considered asymptomatic, no lower back pain. And so what they decided to do is they wanted to do some MRI examinations of lower backs of individuals who weren't complaining of symptoms. And they wanted to take a look at it and see if you could detect any abnormalities. So to make sure that this study wasn't biased, they did a couple of other things too. They took approximately, I want to say 27 scans of individuals who were experiencing pain and who also had abnormalities, and they mixed it in and had 2 neuroradiologists take a look at the scans and try to determine who has abnormalities and who might be feeling pain from that. And ironically, what they discovered here is that 2/3 of the asymptomatic population actually had like bulging discs and protrusions. And so it sort of challenged our assumptions of, is the presence of these sort of like a coincidence, or can you have like these abnormalities detected, but not actually have pain accompany it? And there are many other examples of this too. I think one is of if you look at like neck pain and degenerative imaging that's very present, like only 10% of those individuals where they looked at the imaging were expressing pain. And the alternative to this is, I think this is a very clever tale. So the tale of two nails, that actually comes from Dr. Zoffness. So I'm quoting her here. And these are not real pictures and there's no injury depicted here. I wanted to be sensitive to anyone who might feel uncomfortable with those images. But if you're interested and you happen to Google these later, you can find them very easily. So when I talk about pain in the presence of, in the absence of tissue damage, and even pain in the absence, or I'll get to that. So in this first case, you can see here, there was a construction worker who was working and he was on a ledge and he jumped down. And this is actually a case study in the British Medical Journal. He jumped down on the nail and the nail penetrated his foot and went through the boot. So what had happened is he was in such excruciating pain that he had to be treated with emergency services. So they took him to the emergency department. And there he had to be sedated, I believe, with opioids because his pain was so excruciating. And what they discovered when they removed his boot is actually the nail never penetrated his skin whatsoever. It went between his toes and came out the other end of his boot. So we use this as a case example to say, one, his pain was real. It deserved to be treated. He deserved to have an intervention, and no one questioned whether or not he feels pain. But this leads to sort of that idea that sometimes you can have pain in the absence of tissue damage. And it also tells another story too. And that is how important our brain is in processing pain. And that's never, I want to be very clear, if we say like, pain is processed in the brain, that does not mean that your pain is not real. That's not what anyone is saying. The pain is absolutely real, but the brain plays such a huge role in sort of trying to keep you safe. And so in this case, what is suggested is that his brain was using cues. It used the visual cue of seeing the nail through his boot. It used the information of working in construction and knowing that that can be dangerous. There was also sort of the emotional component, maybe fear and maybe panic. And then in addition to that, there was also potentially the cues of looking at his coworkers and seeing their faces. So his brain put all of that together. And literally, I believe Dr. Zoffness says his brain created pain to keep him safe. Now, in this other example, and again, this is not the picture from the actual case study, but this was a gentleman who was also a construction worker, and he was working with like a nail gun, and it kind of, hit him in the face or just kind of went off, and, he didn't think much of it. Again, he was using his cues, and, he, like, over the next 6 days, he worked, he slept, he ate, and then he decided to go to a dentist. And when he went to a dentist because of dental pain and they did an x-ray, they discovered that the nail had actually lodged into his cerebral cortex, which can be very dangerous. So that's sort of a case where someone actually had tissue damage that could have been very grave, but he wasn't feeling any pain. And maybe that was partially attributed to his brain using cues and thinking, oh, I'm not really in danger. In this other example that I cite here, Beecher, 1956, these were researchers back in a researcher back in the 50s who was examining World War II veterans. And he noticed that people with very serious injury or illness, like the type of pain they the type of pain that they felt didn't necessarily match with sort of the injury. And what he concluded was that really the meaning behind pain was so important. So for those individuals, it meant escape from the war. And these same individuals who weren't really responding with pain to these injuries were responding very painfully to like shots from the nurses. And so this goes when I talk to you about putting meaning behind our pain experiences, what kind of meaning and the cognitions that you have can be really important to your pain experience. Another example that it kind of confounds the medical community and the psychological community is phantom limb pain. So this is pain that people actually feel when they've had in a limb that's been amputated or removed. And again, if you were to ask me the mechanics behind it, that's not something that I can speak to, but I think really the community is still trying to understand and have clarity on this. And this has actually challenged how we view pain and how we've advanced our knowledge. So remember when I talked about expression and how it's so important to include like all of it, the biopsychosocial domains and expression. So I put this up here, like it's probably really rare that anyone would ever come to a clinic or to a provider and use sort of like terms that are relating to biochemical deviations or biological deviations. What people likely do when they're trying to express any type of, experience that they're having that they would like help for, in this case, it could be, I'm having stiffness, I'm having pain, I'm having a hard time sitting or standing for a long time, and I can't really do the things that I want with my family. So expression is actually quite important. But I also want to acknowledge, I think this comes up a lot, that sometimes people choose not to express their pain, or even sometimes, like I fully acknowledge that there's fear of expressing the true extent of it. So I have many people come to me and say, I really feel a 10 out of 10, but I'm actually too afraid to tell my physician or my provider how really intense my pain is, because I'm afraid someone will think I'm exaggerating. So I fully acknowledge there are different circumstances for each person in how they choose to express or not to express, and who to express to, and what level to express that. But again, with the definition of pain, what's really great about it is that it doesn't require expression. If you have pain and you say that, it's believed, and we acknowledge that. But just a few things, like when it comes to expressing pain, there are many different types of domains that you could consider. Sensory, like where do I feel the pain? How would I rate the pain? I know we typically use the 0 to 10 scale, and I think there's talk about expanding that a bit. What is the quality of my pain? Is it throbbing, burning, electric-like, tingling? Emotionally, like how unpleasant is it, and how is it impacting my mood? Does it make me feel depressed? Does it make me feel anxious? And then cognitively, I think this is so important. Like, how do we interpret that pain? Do we think that it's very, is it causing injury or damage? Is there something sinister going on? Do we think of it as, more chronic pain, which I'll talk about, in which, there isn't injury or damage occurring? And how do we respond to it? Are we fearful? Do we see it as a serious, do we change our behaviors because of that? So there are many different sort of things that we have to consider with expression. And again, it's not just verbal, and it doesn't have to be any expression at all, but sometimes there's guarding, maybe in the way that, you could see it on someone's face. There are just many different ways that someone could communicate that pain if they chose to. So so when we talk about onset and manifestation, so, when I mentioned that Dr. Engel had noted that sometimes there are different factors that really change our trajectory, or when a disease starts, or how intense it is. So I'm going to talk about a few that are related to pain that I think are really important, and I think that are really, people are interested in knowing about these specific topics. So this first one is ACEs. If you haven't heard of that, that's adverse childhood experiences. And basically what that is it's an assessment to look at the types of, if any, adverse experiences that you've had before the age of 18. This could be emotional abuse, physical abuse, sexual abuse, neglect. And that can be defined as like maybe you had to wear dirty clothes as a child, or maybe you ever got humiliated by a parent or didn't have enough food to eat. It looks at things like, did you ever feel close or loved by any of your family members? It also looks at like guardians or parents. Was there like separation or divorce? Was anyone in your family ever incarcerated? And there are many other sort of situations like substance use, suicide, or mental illness in the family. And basically what we know about that is that there is a dose-response relationship. So the more adverse childhood experiences that you've faced, or the more trauma that you've had in your life, the more likely you are to develop chronic pain, or for it to be intense. And so that's why if you've ever met with a pain psychologist here at Stanford and you've undergone a pain psychology evaluation, we'll get a lot of questions saying, why are you asking me about my childhood? And this is a huge reason, because we want to assess for any types of adverse childhood experiences, because we know that can, influence your pain experience. Now, if you were to ask why or how, again, I think that's still something that's a bit controversial and people are trying to understand. So there is some discussion about the central stress response system of your body experiencing wear and tear. So we'll talk a little bit about the fight or flight response, which is meant to be acute and in the short term. But if your body is chronically activated, particularly if you are in an environment with a lot of threats around you, that has long-term impact. There's also consideration of, is there like, I guess, a hyper responsiveness in the limbic system. So like, if you've constantly scanned your environments for threats, is that something that kind of translate into scanning your body for threats and having more sensitivity to things that typically wouldn't be considered threatening or painful to other people, but you experience it. So again, I think it's still something that needs to be studied, and we're still trying to understand how that works, but we do simply just have that data to suggest that if you've had these traumatic experience or adverse experiences, those individuals are more likely to go on and to develop chronic pain. Now, that doesn't mean that will have to be your trajectory, because as we know, there are lots of things that influence that. But it also makes sense too, because when, again, someone who's experienced adverse events, it doesn't mean that they're going to go on and have PTSD, but some of the questions that we ask when we're looking for PTSD include, does someone have what we call an exaggerated startle response? Like, exaggerated doesn't mean someone's making it up. It means that if you're exposed to a loud sound or like a sudden sort of like movement, do you startle more easily than other people around you? In addition, one of the questions that we ask is about hypervigilance, which just means, do you scan your environment for threats? And so it kind of makes sense that, these are things that go hand in hand. Another thing that I think is really important is talking about social determinants of health. And social determinants of health are basically sort of like environmental factors. So it's kind of like, where did you grow up? Like, what kind of neighborhood did you play in? Like, do you worship or pray in a certain area or space? Where do you work? How much access to resources did you have? Like money? Were there inequities? Do you experience discrimination based on, race or ethnicity or gender identity or sexual orientation or faith? So it's kind of looking at these things because we know that they impact, someone's like trajectory with any type of disease. And in particular, there's been a systematic review, which basically means that people have looked at all of the research out there and specifically chosen research that meets rigorous criteria. And what they found are a few things when it comes to pain and these social determinants of health. So they have discovered that individuals with a lower education status are more likely to have chronic lower back pain. And that just could be because there's not access to information that could be helpful. For instance, like we'll talk about the difference between acute and chronic pain. Knowing that actually can make a huge difference for someone's pain trajectory. And if someone doesn't have access to that information, it can really impact how they make choices or how they perceive the pain or how the meaning that they put behind it. In addition, we know that individuals who have a lower socioeconomic status or less income, for whatever reason, there's also an association with chronic lower back pain and unemployment and other occupational factors like working a lot, doing a lot of manual, difficult work and not having support. So, and again, that's just for lower back pain. There are many other studies that look at different types of pain and look at social determinants of health to kind of figure out how they correlate. But I think that's important data to have in mind. And then catastrophizing, I think this is important. So what we know in research is that if someone is experiencing catastrophizing, which is basically, it means that you're kind of like, they call it, there's a component of magnification where you're assuming that a threat is maybe the worst possible outcome or as worse as it can be. And so we know that catastrophizing can lead to more disability, it can lead to higher pain levels, it can lead to more distress, it can impact relationships with your loved ones. And so I'm gonna show you a slide later about the importance of modifying those thoughts if you're having catastrophizing. I wanna see if there's anything else I'm missing here. No. In addition, if you think about, if we look at even post-operative or, if someone's having surgery or undergoing an intervention, I've put some quotes here from research so you can take a look at it. And basically what people are finding is that higher levels of catastrophizing, or even, if someone is feeling depressed or anxious, these can actually influence someone's development of chronic pain and or prolonged opioid use after if it's not addressed. So a lot of researchers are suggesting that, maybe instead of putting all of the energy into biomechanical issues or patient characteristics, something that we really need to be focusing on are the psychosocial factors that I've been chatting with you about. Oh, I do want to say one other thing. When it comes to surgery, even having fear about the long-term outcome, like having that fear and it's not alleviated, or and you haven't worked through that, that can actually lead to worse outcomes as well. Let's see here. So perceptions of it. So I do want to say, if someone is fearful, it makes perfect sense, right? There's a lot that you could be worried about. I have made some notes here that sometimes with like chronic pain in particular, you don't always get a diagnosis, or you don't know where that pain is coming from, or maybe you've gotten multiple diagnoses. Sometimes people wonder, how long is it going to take for my injury to heal? Will I be able to go back to work? Am I going to be able to pay for all of this? And is it worth going through all of this if I'm not really seeing sort of the outcomes that I want? So I want to be very clear that having fear is valid. We will never say that having an emotional experience is not okay. It's absolutely okay. It's what happens when that fear becomes a belief. And so if there are beliefs in particular, I'm speaking about chronic pain, that pain that I feel is causing injury or damage, or that I can't ever do anything if I have any pain at all, or I should avoid all activity. When these beliefs become when fear turns into beliefs that are problematic, like that can influence your pain trajectory as well. I also, Dr. Engel talked about relationships. Like, your relationship with your provider is so important. And the research actually shows that if you have a satisfying a good relationship with your provider, and you engage in shared decision-making where you agree with sort of the treatment rationales for what's going on, you're more likely to be satisfied. You're more likely to recall health literacy information. So that's more helpful for you because it helps with adherence to things that are helpful for you. And actually, this one I feel really pleased about. It's that if a patient feels comfortable with their provider, they're more likely to engage in self-care. And sometimes I think self-care is something that can kind of get pushed to the side if someone's experiencing pain. We also know that if a patient is provided with information not only about the procedure and what to expect, but also what kind of pain they might be feeling or what they're going to feel like after, that's actually associated with better outcomes as well. So having discussions and communicating is so important. Now, this study I really enjoy talking about. So this is a study that we had some researchers from Stanford work on, and Dr. Sean Mackey, I've heard him talk about this personally, and he said that basically this was the easiest study that he's ever had to recruit for because people are so excited to talk about love. And what he did is he happened to go to a conference with another researcher who studied love, and obviously Dr. Mackey studies pain. And they were realizing, wow, when we're talking about pain and love, we're seeing a lot of overlap between these two things. So they decided to do a study where they had undergraduates, they recruited undergraduates who felt like they were in that very intense stage of love. So not mature love, but kind of the way that they described it actually was obsessively thinking about someone or craving their presence, because they felt that those beginning stages were very similar to even the stages of addiction. And so they wanted to see, what happens with pain and love, what is the interaction there, if any. So what they did is they took undergraduates and they had them bring in a picture of the person that they were intensely in love with, a picture of an equally attractive acquaintance, and then they had another activity that I'll share with you. And they exposed them to a thermal stimulator that caused mild pain. And so while they were causing pain, they had them look at both of those pictures. And then they also did a distraction activity just to see what would happen. So I think the example they gave is that, they asked them to think about a sport that doesn't include balls. And so what they discovered is that distraction and looking at the picture of the love that they felt very intensely, that person, alleviated pain to the same degree, but when they looked at the scans of the brain, it was using different parts of the brain. So when individuals experienced that alleviation of pain, when they looked at their significant other, basically it was activating the reward center. So this is just to say that even the relationships that we have can influence sort of our pain experience. And then I kind of already talked about this, that sort of treatment, if it's only geared toward biomedical, you're more optimally treated from a psychological and social perspective, in addition to the biomedical aspect. So I think this is really important that when I talk about this, all of them working together is what's best. We want to use what amazing things we've done biomedically, and we want to be sure that we're including the psychosocial aspects of it too. So, I said I'd talk about the difference between acute and chronic pain. I just think this is so important because there is a difference between the two. And this diagnosis has to come from your physician. So acute pain is generally of sudden onset. And usually it's expected because there's a known injury. So the example I give often is if I break my wrist, I know exactly sort of what's causing the pain. And I call it a symptom because I know that in that case, the pain that I feel with acute pain, it's signaling that, yeah, moving is causing injury or damage. And it's a sign from, my brain to tell me you need to stop moving. I'm trying to protect you. It's usually lasts less than 90 days. And sometimes that people kind of debate that. And it's different from chronic pain because chronic pain can be ongoing or recurrent. It usually lasts 3 months or longer. And sometimes you know what's causing it and sometimes you don't. But I think the real difference is that it's at this point, it's classified as a disease because there is no longer just like a single solution that you can use. For most people, maybe that part has healed if there's a known injury and they're still feeling pain. And so we classify that as a disease. And so we treat it from the biopsychosocial model because as you can see here, and as you've probably experienced, it starts to impact other parts of your life. So I'll move on. One of the important theories in pain is the gate control theory. And this is one of the first theories of pain that kind of incorporated the biopsychosocial model. And basically, it's simply saying that there's sort of like a gating mechanism in your dorsal horn. And, there are certain things that open the gate to allow someone to feel more pain or close. And it's not that simple. It's not like if I open it, everything comes through, or if I close it, it stops everything. It's selective about what goes through or what doesn't go through. And so there are things that can open the gate and make someone feel more pain. And some of those things include feeling stressed, focusing attention completely on pain, not being active enough. And there are certain things that can close that gate and allow less of those signals to go through. And that can be feeling content, engaging in pleasant activities, sort of having adequate activity. And also, if we consider the biopsychosocial model, massage or medications, all of these things count. So I just want to briefly run through things so one of the things that we say as like a tip for you as strategies is one of the first things we say is build your toolbox, kind of learn about what do you know in your own experience that increases pain or decreases pain. So here, I go through examples of physical thoughts and emotions and social aspects. So for some people, you can have acute pain and chronic pain at the same time. Again, that has to come from your physician. New injuries could make your pain feel worse. Muscle tension can make it feel worse. And of course, things that can make it feel better, if you're thinking about physical or biomedical, it could be medical interventions or even relaxation techniques. For thoughts, we already talked about sort of the issues with catastrophizing or even focusing on pain. So some of the things that you could do is like modify thoughts to achieve balance or even use distraction. Emotions, again, emotions are not bad, but if they elicit a negative mood state, meaning it kind of causes like concerns for you, that can make our pain go up. So if you're feeling particularly anxious, that can release stress hormones into your body that can cause you to feel more pain. Depression and pain share the same neural pathways. So it's possible that if you're feeling more pain, you could feel more depressed. And if you feel more depressed, you can feel more pain. And then there are definitely things that you can do to decrease it, like engaging in pleasant activities and challenging unhelpful thoughts, which hopefully we'll have a chance to get to. In terms of behaviors, if you're too active or not active enough, that can make your pain feel worse. And ways that you can decrease it is engage in time-based activity pacing, which is sort of like doing an activity and taking a break and doing an activity. Socially, you actually too much support or too little support can make it feel worse. And of course, if you want to decrease the pain, spending time with loved ones, volunteering, being part of communities, that can be very helpful. So I do just want to talk about the chronic pain cycle. And then I will just in the looking at time, I'll try not to go over 551. I might skip ahead to like a strategy that I think is helpful. But really, we talk about the chronic pain cycle. And basically, even if your experience doesn't map on exactly like this, I'm sure there are parts of it that you can relate to. So for a lot of people when they experience chronic pain, whether it's fear of movement, like that fear avoidance of like, I'm afraid if I move or engage in activity, I'll cause more pain. That can cause people to decondition and lose stamina, which then can cause sort of negative. And a negative here is not saying it's wrong. It, like I said, it elicits that unpleasant mood. So that could be depression, anxiety, envy. When people start to feel a lower mood, they start to withdraw from certain activities that they care about, and then it can cause more distress and disability. So in terms of things like, we can break the cycle. If we break the cycle at any point, even if it's one intervention, you can effectively do that. So one of the things that we talk about is just exercise under the supervision of your physician. So we actually know there's been like a systematic review, and engaging in exercise was beneficial. And in fact, it had no adverse outcomes in that particular systematic review, aside from, of course, soreness that people would typically get with exercise. So exercise, can increase quality of life. It can reduce pain intensity. There are so many benefits to that. So if you're able to do that safely and comfortably under supervision, we would encourage that. And I apologize, in terms of time, I want to get to a piece here. So in terms of if you feel like you're stuck in sort of like an emotional state, one of the things that we can do is look at our thoughts. And so these are different types of unhelpful thinking styles and pain thoughts. And I think these are really important to consider. And so I think the skill that I'll end with today is teaching you how to modify them. So these are examples. We've talked about catastrophizing. Should statements, I'll skip down to here, like my doctor should be able to cure my pain, or I should be able to make plans without canceling. It's kind of like holding yourself or others to expectations. All or nothing, like I can't, it's like looking at things in extremes. I can't be happy if I feel pain, when in fact, some people can feel happiness even if they're in pain. Disqualifying the positive, this happens so often. It's kind of like saying everything that I've done to this point, if I've had a pain flare, was for nothing because I'm feeling pain now. So it's kind of like not filtering out the positives and kind of focusing more on the negatives. Jumping to conclusions. So I think this one comes up a lot, like not using knowledge, but maybe just not objective fact to kind of make decisions. And so I'll talk to you about resources here in a moment. If you work with a psychologist, this is something that we can help you identify and modify. So I'm going to go ahead and skip ahead then. So one of the ways, I'll just teach you the skill, it's catch it, check it, change it. If you are trying to work on some of your thoughts, what you do is catch the thought and identify what is the thought that I'm having. And then you check it and ask yourself, is this helpful for my mood, or is this not really helpful? And then once you've decided that it's unhelpful, what you can do is challenge it. And I'm really clear. I don't say that people have to be positive per se, but what I say is that you want it balanced. So there could be truth to this. Like in this example, I'm having the worst pain I've ever felt. I maybe shouldn't have gone out with my friends. Maybe it is really true that you're having the worst pain that you've ever felt. However, they're balancing it out here by saying, I'm having pain now, I overdid it, but I can pace myself in the future.